All right, so yeah, I really don't have to do this talk. Thank you to Dr. Razavi for doing a lot of it. um, all right, so my slides up. Okay, so just to and really, you saw we've had a lot of debate already. Any CLI case, this can come up. So anyway, this is one of my cases. An 86-year-old guy who has non-ambulatory chronic osteo. You can see his wounds there. Came in for a second opinion after he was told he needed amputation. I actually was one of the rare cases that I told him he should have an amputation. Um, anyway, vehemently declined, and with a lot of angst and sort of a moral dilemma, we did do an angiogram after a duplex showed basically this, occlusion of his anterior and posterior tibial and a tight TP trunk there. So we did, put a stent in his TP trunk. It was a very large TP trunk. And the question is this enough? You see where his wound is. It's been the Achilles area. He's got collaterals to the dorsalis pedis. But how do we know if it's enough or not? And again, the bottom line, as Dr. Razavi said, is we don't know. Right now, there's not good data, not good technology to tell us if it's enough. So a lot of times we do rely on, stage procedures, wound trajectory, seeing how the patient he does in the next, 2 to 4, usually 4 weeks. So anyway, I'll leave that and we'll finish that later. So bottom line is endovascular treatment of CLI has been shown to be effective in preventing amputations. And we want to improve perfusion, ideally inline flow to the lesion, and that's the theory behind angiosome-directed revascularization. But how much is enough? And so we know that ABIs really are not good indicators for CLI. You can see here, 29% of patients with tissue loss actually had normal ABIs from this paper. Sorry, I'm not seeing it on these monitors, so I'm having trouble. But toe pressures are a little bit better in terms of diagnosis and prognostication than ABIs. We already saw this slide. This is just a good example of a podiatrist that called me and said, "Hey, this guy had a rip roaring infection. We had to, IND him, but the bottom of the foot is having trouble with hemostasis, but the top of the foot looks ischemic." And so, he's like, "Is that possible?" So I launched into the whole angiosome thing, and it correlated very nicely with his angiography. Here you can see an anterior tibial artery that's occluded, and that's why he's ischemic on the top of his foot. Again, regurgitation of the data showing that direct revascularization seems to be better than indirect revascularization. But there are caveats to that. So if you have collaterals, like Dr. Razavi said as well, you can see the bottom graph. If you have good collaterals, the direct to indirect revascularization benefit goes away, it seems like. And also there's data showing if you have an open pedal arch, it also is a very big predictor of wound healing. So again, we think more extensive revascularization is better, but again, it's expensive, time consuming, not without risk, right? You touch something, you initiate a restenosis pattern, potentially. You go through the pedal arch, there's this phenomenon of sort of, pruning vessels and the pedal arch itself actually, just from you passing through it, becoming restenotic. Wound blush is a good thing, but we're going to talk about some newer perfusion techniques. And again, this is just another case example of how do you know in a guy like this, he doesn't have a good toe to do digital pressure. You can't really rely on ABI because he's non-compressible, and so on and so forth. So let's skip that. So TCPO2 is older technology. We actually don't even have it at our hospital anymore. It takes time. You have to warm up the probes. A good study takes 45 minutes. It can be hard to reproduce. Laser Doppler cameras can be bulky. It's more of a experimental protocol at this time. Hyperspectral imaging is nice because it's non-invasive, but it takes time. So you can see the pre-intervention, post-intervention image in the middle, but it takes 60 minutes for it to really catch up. And that's not practical on the table. We did have an injectable sensor called the Lumi, which actually, unfortunately, through COVID, they've abandoned that project, but that did give us some information that was, quick and reliable. And then Dr. Razavi talked about the FlowMed system, which is a laser speckled tracking system that shows us some flow. But again, you have to have a toe to put that on. Here's the Lumi, again, which has been abandoned for now. I think it is available in Europe and not in the United States. And again, it's just an injectable sensor that can be read on the outside and can be read continuously. There are some other fluorescent type imaging. The SPY system, I think, who bought them? I think it was Stryker. This is mostly used for like flap for vascular surgery for flap viability. There were some initial studies looking at critical limb ischemia. I haven't seen anything really in the recent last 2 years or so, but trying to be more quantitative. But you get an idea of sort of an IV injection of a certain dye that can be picked up. Now, Philips, Siemens, and I believe Toshiba all have this parametric imaging that they're looking at. And basically, it takes your angiographic image and it sort of quantitates it in terms of the time for the contrast to reach an area, speed, and also the amplitude. And it color codes it. So these are the kind of images you get. And obviously, the faster and the more robust the contrast is to the area, the better the perfusion is. I haven't used these in my practice, but they are available. And I think the challenges are you have to do the exact same image. So again, the foot cannot move, same injection, same view, et cetera, et cetera. And I think that's the limiting factor. And again, I think there still needs to be some validation of these techniques. So the last thing I want to show you is this PEDRA technology that actually got breakthrough status with the FDA in June, I believe. And they're hoping for some sort of approval here in the next few months where they can do a trial to get a 510K approval. This is also similar to the FlowMet in that it is a laser speckle tracking. But instead of going through the toe, this is actually reflective. So you have one sensor that transmits and the other one that receives. It can penetrate down to 8 millimeters in depth, and you can see the user interface is pretty easy. It basically gives you a readout on the right, and it has 4 sensors that you can put in different parts of the foot. You don't have to be on a toe. You don't have to cuff it like the SensoLay system. So potentially has a lot of appealing factors. It's non-invasive, and it's quick. The delay is like 10 seconds. Let's skip this. So this is just some earlier work showing, when you do an angiogram, balloon up, balloon down, it correlates nicely and gives you this blood perfusion number, BPI. And it seems to correlate well with toe pressures, and it's pretty instantaneous. So our gentleman, just to show you the case, again, because of the location, we didn't think he had enough. So we actually stuck the occluded posterior tibial, got back up into the TP trunk, ballooned that. Later, we stented that, but we had to open the arch. So we actually went antegrade from the dorsalis pedis, and we eventually got that around into the posterior tibial. We ballooned that while we removed our sheath to restore the plantar arch. And here, he had good flow to the angiosome area, angiosome-directed area. And slowly but surely, he did finally recover and heal that wound. So bottom line is we don't know when enough is enough. I think you have to be practical. I think that staging is not necessarily a bad thing. Wound trajectories, seeing the patient every 2 to 4 weeks. I think that there's a difference between opening a 250 millimeter anterior tibial occlusion versus a 3 centimeter posterior tibial occlusion in terms of ease of use, ease of the procedure, complication rate, and patency rates. So I think those are all factors. But again, having something on table to tell us when enough is really what we're trying to strive for. And I showed you some of the technologies that may get us there, hopefully in the near future. Thanks.